I know there may be questions, and hopefully we'll take them at the end of the day if Tommy can hang around a little bit. Our next speaker is Dr. Andrew Beck. Andy earned his MD from Brown Medical School, completed residency and fellowship training, and a PhD at Stanford. He's been certified by the American Board of Pathology in anatomic pathology and molecular genetic pathology. He currently is the co-founder and CEO of PathAI. And the title of his talk, I believe, is Artificial Intelligence for Pathology, from Discovery to AI-Powered Companion Diagnostics. Welcome, Andy.
Thank you. All right, well, thank you so much for having me at this great event today. It's really an honor to be a speaker in this session, I think, covering so many really important areas of AI and machine learning for our understanding of disease, leading to improvements for patients. And I'm going to focus on a very specific area where I think AI could really make a major impact in the near term in advancing medical care, and that's in applications in pathology. And pathology is really the area of medicine that a lot of patients may not know a lot about because it's sort of in the laboratory, and the only job of pathologists really is being good processors of information, where they take as input information about what's happening to the patient, and that almost always includes a patient tissue sample with it, and it could include information about what the radiologist saw or what the clinician saw treating the patient in the clinic. And the pathologist's job in the lab is to integrate this input information with what they see in the tissue sample, define what the disease is, the diagnosis, and then that diagnosis will be considered the definitive diagnosis that will lead subsequent treatment decisions. So it's really the bedrock of medical research and also clinical practice. And it's a pretty conservative field. The core technology in pathology remains the microscope, which is an incredibly valuable tool. The microscope was first developed for this kind of use in the mid-19th century. So pathologists are looking at glass slides containing tissue samples, and really just with the naked eye viewing on essentially conventional traditional microscopes the disease process. And these disease processes, as we all know, are incredibly complicated and have many, many diverse patterns, hundreds of thousands of cells in each sample. And the way the cells are visualized, sort of the standard method, is this H&E stain, which was first developed again in the late 19th century to enable humans to visually interpret what's going on these tissue samples. So it's a very old-fashioned set of technologies that are trying to use to enable physicians to make a really, really complicated decision about what is the disease process based on the analysis of literally hundreds of thousands of cells. So just because the technologies are old, doesn't mean they're bad. But the problem is, in many areas in pathology, there's really significant inter-observer variability in the interpretation of the same image. And I think for kind of a machine learning group, we can think about this, again, as a data transformation problem, where each column here represents one patient sample. So essentially, each column has the same input for the same column. And the output of the pathology diagnoses, when each of these samples was shown to a group of community pathologists, is represented as a color. And what you can see is, in a computational system, even if it didn't work very well in terms of accuracy, in terms of reproducibility, it would always produce the same color in each column. Same input should produce the same output. What we're seeing here is the same input in terms of patient samples is producing a variety of outputs, with the whitish color being benign diagnosis, which the clinical recommendation would be no subsequent treatment needed, yellow atypia, and orange in situ cancer. So you can see this is really disturbing data showing just the level of variability for this critically important diagnostic area. And in this study of breast biopsies, they report an overall concordance rate of about 75% for all the different diagnoses. And what we're showing here is one of the most difficult diagnoses, atypia, where there was a concordance rate across pathologists of only about 48%. And even more surprisingly, the intra-observer concordance for this difficult diagnosis was just 53%. So essentially, the same pathologist shown the same set of slides 8 or 9 months later only gave the same diagnosis just over half the time. So clearly this is a problem where computational systems should be able to help us. And that was an example in difficult diagnoses in breast biopsies. The same research group also looked at skin biopsies, another one of the most common biopsy types, and found remarkably similar results where, for example, these are called class 3 kind of middle tier of risk of melanocytic lesions, which is something like a nevus or, in a malignant case, a melanoma on your skin. And each column represents a case that a group of expert panels called Class 3. And what you can see is that across the community of pathologists, there's really a wide distribution between people saying it's completely benign nevus to saying it could be a melanoma in situ or even a T1B melanoma. So this is incredibly large amounts of variability. And again, in this study, they showed it's not only disagreeing across people about what they're looking at, but even the same person gives a different result about half the time when they're shown. It gives a different result a third of the time when they're shown the same image 8 months apart. And this is a problem in breast biopsies, skin biopsies, and the College of American Pathologists has recently published a big review across pretty much every study published in this area of inter-observer variability over the past couple decades, and reported an overall discrepancy rate of about 18% for minor discrepancies and 6% for major discrepancies. So again, high error rates are not limited to any one diagnostic specialty, they're not limited to individual pathologists, and it really is a systemic problem that could be addressed with some recent technology advances. So this has been a big problem for decades, and there's a lot of reasons, that we could be pessimistic about that, but this is one of the few areas of medicine where there's really been proven over the past 5 or 6 years that an AI-based solution has shown incredible improvement in other highly adjacent and highly relevant areas. So in terms of hype, or is there not hype, it's always hard to interpret when is something overhyped. But at least the one area we've seen computer vision AI and deep learning make remarkable advances is the area of computer vision. And we actually haven't seen this plot yet today. And you see this almost always in deep learning, machine learning Symposium, just because it is such powerful data. And this is the error rate from the ImageNet Large-Scale Computer Vision Challenge, which is a large-scale competition that includes teams from academia and teams from within industry, where it's really the scientific community's goal to build the best computational system to reduce errors as much as possible on a set of real-world images. So essentially, there's a training set and a validation set, and these images are provided to the community of researchers. And the best winning team back in 2010, which is not that long ago, was making mistakes almost a third of the time, which is kind of similar of the order of what we saw for the disagreement among breast biopsies, for example. But between 2011 and 2012, deep convolutional neural nets were first incorporated as a model type used within this competition, and they saw a massive improvement in error rate. And the whole community took note, and it's a very, very competitive community who reads the literature and publishes really aggressively. So between 2012 and 2015, essentially all of the top 10 entries in the competition were based on deep convolutional neural nets, and they kept making the methods better and better, where they saw this real year-over-year strong incremental growth, where by 2015, which is 4 years ago now, the best systems in computer vision were performing at or better than human error rate for well-defined visual tasks. So this is one area of AI where undoubtedly there's incredible recent technology improvements, and why we think most of the areas of medicine that are going to be most significantly transformed in the short term are going to be vision-based. And we've heard a lot today about radiology. Pathology is another very, very highly visual area of medicine. So we were one of the first research groups back in 2016 that really tried to apply some of these new methods in deep convolutional neural nets to problem areas in pathology. And this was kind of the pathology version of the ImageNet Large-Scale Computer Vision Challenge we saw before, where the image data set was entirely based on pathology images, but it was the same setup where there were teams from across the world where the goal was to build an algorithm that could automatically do a task that used to be done manually. And here's the basic setup for the way this worked is the system for training is provided with a set of whole slide images, and the whole slide images are labeled for the object that we're trying to train the system to detect. And the thing to know about pathology images is they're very, very large. So you could actually think of each image as a collection of tens of thousands or hundreds of thousands of smaller images. And really the size of the training data set you need is really scales with the size of the objects you're trying to detect or trying to make predictions about. So if you're trying to make predictions about an individual patient, you may need tens of thousands or hundreds of thousands of patients. But if you're trying to make predictions about individual cells, you may only need hundreds of cases because each case contains hundreds of thousands of cells. So that's one kind of unique insight about this vision problem in pathology is each image is a collection of many, many small images. You need a labeled data set, which is one of the major challenges. But once you have that, you can sample many, many examples of the object of interest, in this case tumor, or the background object, in this case normal. and then feed those training examples into a deep convolutional neural net to build a system that can then take unlabeled images, break them into tens of thousands or hundreds of thousands of sub-images, and put all of these individually in parallel through the same trained deep network, and then make all of these predictions in parallel on an unseen image. And then in this case, you can visualize what the deep learning system is seeing as a color, where cancer is represented by red and normal is represented by blue. And to give you some example of what this really looks like and what the core task in pathology is, this is just one slide from one case from one patient. And this would be a tiny, tiny fraction of the type of work a pathologist would be asked to do in a day. But even on this one slide, if you look at the tip of my cursor, like this probably represents a few lymphocytes. And the real job of the pathologist is to ensure that there's not a single metastatic cancer cell on this lymph node. So really, if you had unlimited hours in the day and unlimited brain capacity, you would want to actually study every lymphocyte or every area of the lymph node to make sure it's all normal cells and no cancer cells. And that's just very infeasible to do using manual approaches with just a microscope. But with the assistance of an AI system, we actually can force and do force the AI system to look carefully at every single cell and then to visualize what it's looking at as a color. And here we're visualizing, again, cancer as red, non-cancer as blue. And now when the pathologist sits down and looks at the same case, they can really focus their super limited and super scarce attention and time on the regions that have already been carefully pre-screened by the AI system. And then see in this case, now from low power, where in one field of view you can see the entire lymph node, you can see that this tiny little hotspot in fact represents maybe a population of 20 metastatic breast cancer cells on the edge of this lymph node, easily could have been missed without highlighting it, or this tiny little hotspot here represents 5 or 6 metastatic cancer cells. And now these all are visible to the pathologist immediately from low magnification. And this competition initially was carried out in 2016, and it was published in JAMA in 2017, and I think is one of the most compelling published examples of deep learning being useful in a medical space, where the winning system that was a collaboration between, at that time, my research lab at Harvard Medical School and folks at MIT as well, working in the computer vision group in CSAIL, where our winning deep learning model achieved an error rate of 0.65%, whereas the pathologists in competition, where they weren't limited by time constraints, had an error rate of 3.5%, and pathologists in clinical practice had significantly higher error rates, where they're much more constrained by time. So this was kind of the data that really, to me and to us who formed the company, made it sort of obvious that this should be the future of the way this medical specialty is done, both for clinical research as well as for clinical practice. But there's a ton of infrastructure and data assets that need to be built to really do this effectively. And this includes systems for storing data at scale, importantly for labeling data at scale, which I do think in all applications of machine learning tends to be the biggest limiting factor, is do you actually have enough labeled data to train effective systems? A system of deep learning algorithms to try to predict everything from what is each individual cell to what are tissue regions to what are the implications for patients, and then a web-based system for serving all of these results. And there's really applications across all image-based things in pathology, ranging from research to the development of new tools to better select patients for new therapies, like companion diagnostics, as well as routine clinical diagnostics, like the metastatic lymph node example. And the one aspect I'm going to focus on that we've really invested heavily in building at PathAI, and I think is generally the limiting factor in applications of deep learning in healthcare, is how do we get really high quality labeled data that's labeled by experts? And how do you do that at scale so that when a new project arises, you can immediately generate new data? Or even do it in an iterative fashion where the pathologists are constantly improving the outputs of the models through actually directly integrating with model outputs. And the way we've done this is by working really hard with the pathology community to enlist their services in the work we do, and then collecting and structuring millions of clean annotation data that we can then use to train deep learning models. And a lot of the work you do for practical applications of ML in clinical settings is all about cleaning data. So first, how do we get high quality annotations, millions of annotations from hundreds of pathologists, and then how do we train a bunch of deep learning models to do all the difficult things that pathologists do without even thinking, like train systems to automatically identify artifact and out of focus areas and marker and dust and whatever other things are encountered in the real world. And then how do we train systems to do things like automatically identify the tissue regions and every single cell type within every single tissue region? And with this sort of rich data set, you can begin to extract hundreds or thousands of very specific biological hypotheses from every pathology sample. And then if you link that with things like clinical outcomes or underlying molecular data, you can begin to make new discoveries. And one area we've focused on immediately was the area of immuno-oncology, where there's such a critical role of understanding the interactions between tumor cells and immune cells. And even from the very beginning, the PD-L1 IHC biomarker appeared to be a very important biomarker where patients who were negative did not benefit from treatment. And things like H&E stained slides and PD-L1 stained slides have been incorporated into clinical trials in the area of PD-1 inhibition from the very beginning. And so then there's been a real explosion in numbers of trials, as well as the complexity of the trials, where there's hundreds of different trials being tested for all different types of combination therapies. And pathologists are really overwhelmed by all of these new data. And how can you, in a non-data-driven way, figure out what are the pathologic features that are going to predict response to all these different types of precision therapies? And the only tools they have today are to look at images like this and to estimate by eye what are the proportion of brown, say, immune cells and proportion of brown tumor cells. And you can imagine just on this little field, it would take 20 minutes to actually count every cell, the positive ones and the negative ones. And if you showed this to 5 different people, you might get 3 or 4 different answers. And then when you realize that one field of view is a tiny fraction of a single slide from a single patient, you realize how unscalable the current system is. And recent data has shown this, particularly for the scoring of PD-L1 on immune cells, where the inter-observer agreement is extremely low, only 0.2 as cited in this study. And at the same time, we're actually building companion diagnostics focused on things like pathologists scoring quantitatively PD-L1 expression in both tumor cells and immune cells. And there's now 4 of the 6 companion diagnostics incorporating PD-L1 expression that are asking pathologists to quantitatively estimate PD-L1 expression on the cell type, which is extremely difficult. And there is a lot of hype about AI, and it's very bad at a lot of things, but one thing it is quite good at is just labeling and counting many, many cells. So here, for every cell, the color represents the type of cell it is. Is it a green lymphocyte, a blue fibroblast, an orange macrophage, a red cancer cell? And is it expressing PD-L1, which is represented by the yellow border? And if we can do this well on one cell, we can do this well on, 1 million cells in a given slide. And we can do this very scalably because we can process all of those little fields of view in parallel in the cloud. And this gives us, our very small company, an incredible amount of scalability, where we did this computation where I think we classified billions of cells last year. And if you ask pathologists to actually count individual cells and realize how long that takes, that represents something like 15 times more cells than all US pathologists could collect in a year. So AI-driven pathology is going to be a really powerful technology for very routine things like identifying cell types, counting them, and when you do that at scale, it can really lead to new biological discoveries. The area I'm going to end on in today's talk is not just doing routine things like counting quantitative measurements, which can be incredibly important for making clinical decisions, but really think about how microscopic images represent the functional phenotypes at the cellular and tissue level of a lot of underlying molecular alterations, and that we've had very good scalable quantitative technologies for measuring the genome, transcriptome, proteome, and metabolome developed in recent years. And it's really only now with the power of deep learning that we're applying that same methodology to microscopic images and then to really understand how these all integrate to impact clinical outcomes. And this is one example from TCGA where we can examine all of the whole slide images, automatically identify all the tumor epithelium, the tumor stroma, and every single cell and every single slide, and know where it's located, extract quantitative phenotypes from these slides, and then ask in a purely data-driven way, what is the pathology associated with prognosis in malignant melanoma? And that's what we're showing here on this plot on the left, is every dot represents one pathologic quantitative phenotype automatically extracted by our system, and the phenotypes in red are the ones significantly associated with survival. And it turns out that all of these top phenotypes tend to have to do with the presence or absence of inflammation and subtypes of inflammation in melanoma. The Kaplan-Meier plot on the right is showing one feature that emerged as top ranking, which is increased area of stromal plasma cells associated with improved survival. And then we can actually go and look at the images and see a patient, for example, who did very well with her disease, which was loaded with these individual plasma cells in the stroma of the melanoma. And then we can ask, if we have high throughput RNA data on all of these patients, RNA-seq, what are the RNAs driving this morphologic signature? And in a purely data-driven way now, we've identified a set of pathologic phenotypes associated with survival, as well as a set of RNAs highly correlated with that pathologic phenotype. And we've been doing more of this work with a lot of our partners in areas of drug development. I'm going to quickly talk about a a recent study we did with investigators at Bristol Myers Squibb, where we asked a very basic question: what are the RNAs underlying the three important pathologic phenotypes of immune response? Immune desert, where there's no immune cells within the tumor; immune excluded, where most of the lymphocytes and immune cells are focused on the outside of the tumor and are not effectively going inside the tumor to kill the tumor; or immune inflamed, which is the best environment for good response to immuno-oncology agents. And we essentially used our system to automatically identify tumor stroma, to automatically quantify exactly where the CD8 positive T cells were. And then we can use that to, in a data-driven way, have a quantitative way of classifying patients as either the inflamed phenotype or the excluded phenotype, and then to identify the specific RNAs underlying these pathologic phenotypes. And you can see some RNAs, for example, CSF1R, which are downregulated in the parenchymal CD8 gene expression signature and upregulated in the stromal CD8 gene expression signature, suggesting this wouldn't have been identified in sort of a bulk tissue analysis, but once you start simply integrating AI-powered analysis of spatial location within the tumor with the bulk RNA-seq, you can begin to uncover these patterns. And we really are interested in uncovering new hidden patterns in pathology slides, not just quantifying and automating tasks which are done manually today, but also actually using deep learning to fundamentally rethink how we do pathology. And we work with great partners, such as here, citing some of our work with Novartis. And certainly the technology areas are sometimes the most exciting in the area. I think we've seen the most dramatic progress over the past 5 years, but to really change clinical practice with this, we're gonna have major advances in technology, regulatory, working with regulators to make sure these systems are safe and effective, as well as what are the financial incentives for labs and health systems to begin to adopt this technology. And finally, how do we transform workflow from something today that's largely manual to a very digital and AI-powered discipline. So we're really only at the very beginning of this change of the way pathology is done. So in summary, pathology provides the ground truth diagnosis for cancer research and practice. AI-powered pathology offers great potential for increasing accuracy, efficiency of routine tasks, as well as treatment and response prediction in the setting of clinical trial analysis. There's a whole future, and I think we're only at the tip of the iceberg, with integrating with other high-dimensional data types to enable characterization of new diagnostic and therapeutic targets. And this technology offers great potential for driving new insights into cancer pathogenesis and patient outcomes. I want to thank the team at PathAI who assisted greatly on this work. As many people have mentioned, we're also hiring at PathAI, so I'm happy to discuss more with folks after the talk, and thank you so much for your attention.